All right, thanks very much. I'd just like to thank Binay for the opportunity to come and talk to you today. So I'm going to tell you a little bit about a clinical trial we've been doing at Fred Hutch using CD19 targeted chimeric antigen receptor modified T cells to treat patients with B-cell malignancies. And I obviously have my disclosures here. So I don't think this audience really needs any introduction to the biological role of T cells. They're a component of the immune system. Suffice it to say that T cells have this capacity to kill target cells in a highly specific manner. So it doesn't really take a genius to sort of move from that thing that if you've got a cell that can kill another cell, gee, maybe it could try and kill a cancer cell. And that's something that's been done for really many years, that we've tried to use T cells to treat cancer. And this little sort of schematic shows you what is generally done in T cell immunotherapy. Basically, patients have T cells collected. In the past, it's been a situation in which T cells have been repetitively stimulated with antigen derived from the tumour. This could be peptide, could be whole tumour cells. And then over the course of 2 or 3 months, and this is important, you end up with an enriched population of tumour-reactive T cells that can be reinfused into the recipient. And in the clinical trials that have looked at this sort of approach, there have been very impressive responses, but they've been incredibly sporadic, and overall the results have been really disappointing. And one of the reasons for that is probably that this process of repetitive antigen stimulation is actually driving exhaustion of the T cells. So by the time you get to this point, the T cells are really done. They work in vitro, but they don't work in vivo. So more recently, we've had developments in genetic modification of T cells, and that's allowed us to actually engineer T cells to express a receptor that can recognize a particular target antigen. So this genetic redirection of specificity has allowed us in a very short period of time, now down as little as 1 week, to take T cells from the patient, engineer them, produce this highly enriched population of tumor-reactive T cells that importantly are actually still competent and they're not exhausted, and they can be reinfused back into the recipient. So you can redirect tumor specificity, redirect T cell specificity to tumours with engineering T cell receptors, but we and many other groups have chosen to use chimeric antigen receptors. And a chimeric antigen receptor is basically a receptor that's a combination between an antibody and a T cell receptor. So the extracellular domain of this chimeric antigen receptor here, shown in red, is comprised of a single-chain variable fragment from a monoclonal antibody directed against a tumour antigen. In the case of B-cell malignancies, it's CD19. So this is an antigen that is specific for the B-cell lineage. There's no off-lineage expression, and it's quite highly expressed and stably expressed on a majority of B-cell malignancies. So this tumour-targeting scFv is then fused to intracellular T-cell receptor-derived signalling molecules. And the advantage of this approach is that when you actually signal through a normal T-cell receptor, you need a whole pile of signals that actually come from the target cell to get full activation. And tumour cells are really good at downregulating those signals. So immune escape is very, very common through a native TCR. With a chimeric antigen receptor, you can actually build in inline co-stimulation. So every time the scFv gets ligated, you get the full hit of activation by building in co-stimulatory sequences into your receptor. There's no HLA restriction as you would have with a native TCR. So really it ends up with the situation is that all you need is the tumour antigen on the surface of the T cell. So I should have added in one of the disclosures that I actually have a mouse slide in here, and so this is the mouse slide. But our lab's had an interest for a long period of time in whether or not different subsets of T cells might have different functions. So when it comes to CAR-T cell engineering, one of the questions we had was what subset of T cells should we engineer? And so what we did was take some mice, and they were inoculated with a B-cell lymphoma cell line that was luminescent. We could monitor the amount of tumour. And 7 days later, they received CAR-T cells that were manufactured from distinct T cell subsets. And then we could look at the survival of the mice. And at least in the CD8 compartment, you could see that the mice that received CD8 central memory-derived CAR-T cells, this is just a T cell subset, one of the less differentiated ones. These mice did better than those in blue that had more differentiated subsets. And moreover, if you actually combine CD8 central memory T cell CAR-T cells with CD4 CAR-T cells, you get this synergistic improvement in response. So this is CD4 alone, CD8 central memory alone, and the combination in the same total cell dose, by the way, is highly effective. So this is something that we're obviously very interested in, and it's one thing to try and cure B-cell lymphomas in mice, but we wanted to try and dig a little deeper and see whether there was actually relevance further in humans. So obviously we set up a clinical trial, and we're not the first people to study CAR T-cell therapy. UPenn, the NIH, Memorial Sloan Kettering had highly active trials that preceded us, but our trial, I guess, was a little different in that it used this defined subset composition approach. So the objectives were really to look at the safety and feasibility of this approach. Patients who are eligible, although I've just said relapsed and refractory CD19 positive B-cell malignancies, these were very bad players. Many of them were coming straight off the plane, straight into hospital. Many of them requiring pulse methylpred, these sorts of things that exhausted all therapeutic options. So they were really a bad group of patients. And we had no inclusion or exclusion criteria based on ALC or test expansion, so we're sort of taking them as they came. We engineered a lentiviral vector, and this is basically just a way of genetically modifying the T cells. So this is the vector here. It contained this truncated human EGFR, and this is basically a tag, so we can monitor the CAR T cells by flow cytometry. I'll talk about that later on. So the patients underwent a leukapheresis. That was split into two aliquots for selection of CD4 T cells and CD8 T cells, and they were separately cultured in vitro and then formulated at the end in a 1-to-1 ratio. And the patients received lymphodepleting chemotherapy, which I'll discuss in a bit more detail, and then about 48 to 96 hours afterwards they get the CAR T cell infusion, and we investigated 3 different doses of CAR T cells. So I'm going to start off and show you some of the data from patients with ALL. So these patients all had disease at the time of treatment with a median of 17% blasts in the bone marrow. 7 of them had extramedullary disease, some of them including CNS disease. They were all fairly heavily pre-treated. Many of them had failed prior allogeneic transplant. And about a third of them had a non-cyclophosphamide and fludarabine regimen, and 2/3 had Cy/Flu. I'll talk about that later on. Lots of these patients, around about half of them, had very low blood T cell counts, so ALCs below about 500 or so. But we were able to make a CAR T cell product for every patient, and in 92% we were able to hit that 1-to-1 ratio. And in about 3/4 we were able to deliver the CAR T cells and the chemotherapy as outpatients. 36 patients have completed response assessment at the time this slide was made. And of those 34, all had morphologic CR for what that's worth in ALL. If you then go and look at the patients that had CR by high resolution flow cytometry, it's basically 94% of the evaluated patients were in CR after a single dose of CAR T cells. We looked at IGH deep sequencing to try and get some sort of assessment of the depth of CR. This was done extremely early after therapy, between 2 and 3 weeks after therapy, and 65% of these patients had an undetectable index clone. Many of them subsequently became negative when we looked at later time points. Responses were not just limited to marrow responses. 86%, or 6 of the 7 patients with extramedullary disease were able to clear their disease, and even those with really quite bulky extramedullary disease were able to clear it. The obvious question is, what are the CAR T cells doing? So these are flow plots. They're gated on CD4 T cells and CD8 T cells in blood. On the y-axis we have this EGFR-T, which is just the marker of CAR T cells. So everything in the box up here is a CAR T cell. So what you see is this gradual sort of expansion, peaking around about a week to 10 days after the CAR T cell infusion of CAR T cells in blood. And if you look at this on a graph and sort of think about what's happening at the time, when the CAR T cells first go in, depending on the dose, you often really don't see much action in the first few days. The CAR T cells signal, they get activated when they see tumour, they proliferate, they begin to secrete cytokines. Patients will often develop a fever, require a hospital admission. And then when the numbers of CAR T cells really head north, that's when you start to see the toxicity, and I'll discuss that a little bit in a moment. But you can see in the blood between day 3 and day 7, this is a log 10 scale. We have about 100 to 1,000-fold increase in the number of CAR-T cells in the blood. So there's this massive sort of activation of the immune system and anti-tumour T cells. And the idea is that you get your anti-tumour response in here, where you have this high number of effectors, mimicking what you would see in an antiviral response, clearing EBV or CMV. And then with a bit of luck, if you have functional CAR-T cells persisting, you end up with a surveillance to prevent relapse down the track. So in the early part of our trial, there were 12 patients who received what for the purposes of the talk we'll call low-intensity lymphodepletion. It's not that low intensity. It's cyclophosphamide with or without etoposide. And 10 of the 12 patients got a marrow CR, so things look great at that stage. But 7 of the 10 patients who got into CR actually relapsed, and they relapsed relatively early, within about 3 or 4 months after the CAR-T cell infusion. And that relapse was associated with loss of CAR-T cells in blood. And we're able to actually determine that those patients were immunologically rejecting the CAR-T cells. So the CAR transgene, that new gene you put in, is actually a neoantigen. It's something that these patients' immune systems had never seen. So those CAR-T cells were essentially seen as foreign. Even though they're autologous T cells, they're seen as foreign and they were being rejected. So this is obviously a problem, that you could get great effector responses, but we couldn't get the persistence that we needed to keep these patients in remission. So we looked at whether or not intensification or at least modification of the lymphodepletion chemo before they got CAR-T cells could improve outcomes. And the idea of that was that if you added Fludarabine, for example, to the cyclophosphamide, you would inhibit the capacity of the patients to prime an immune response against that neoantigen. Same reason patients who get Fludarabine are more susceptible to viral infections than those who don't. And what we found was that when we did add Fludarabine, we're looking at the CD4 CAR-T cells in blood, CD8 CAR-T cells in blood, number of days after CAR-T cell infusion. And the patients in red who got Fludarabine, you can see had a much higher peak of expansion. Again, we're looking at a log 10 axis, so 10 to 100-fold higher expansion. And then persistence was 100 to 1,000-fold higher. So huge difference that was made just by the addition of Fludarabine in the lymphodepletion regimen. And in terms of the longer-term outcomes, we saw that there was a big improvement there. So the patients who got Cy/Flu, looking at disease-free survival on the left and overall survival on the right, did much better, these guys in red here, than those who got cyclophosphamide and etoposide without Fludarabine. So Fludarabine was a big player, and the capacity to get CAR-T cells to hang around is really important in these people. Despite that, even if the CAR-T cells do hang around, you can get patients who will relapse. So this is just a graph showing 2 patients, CAR-T cell numbers on the y-axis, number of days after infusion on the x-axis. And you see both these patients had plenty of CAR-T cells in the blood at the time that they developed relapse disease. So the question is, are these CAR-T cells working? Well, both patients had profound B-cell depletion, and this is a great marker of functional CAR-T cell activity. So they both had B-cell depletion, so their CAR-T cells are still working. When the CAR-T cells stop working, B-cells come back. So if you ever have CAR-T cell patients that have been treated and their B-cells bounce back early after the treatment, you start to get a little bit nervous. So the next thing that you think about is, if the CAR-T cells are actually functional and they're working, is the target antigen still there? And so one of the patients actually relapsed with a CD19 negative ALL. So you can see in red are the CD19 positive blasts before CAR-T cell therapy. Day 14, after treatment, they're entirely cleared out of the marrow. And at the time of relapse on day 106, these red ALL blasts are now CD19 negative. And the mechanism of this has been described by Grupp's group at UPenn. It's due to alternative splicing of CD19 transcripts. We actually described and published in Blood earlier this year another mechanism of CD19 negative escape, and this was actually by lineage switch. So we had a few patients with MLL rearranged ALL, and these patients, as you know, are sometimes prone to biphenotypic leukemias or mixed lineage. The MLL rearrangement can be found in ALL and in AML. This patient, as you can see in red, the blast was CD19 positive with really minimal expression of myeloid antigens prior to therapy, lymphoblast morphology. Day 30, she got into remission. Day 35 after CAR-T cells had this explosive relapse with a myeloid leukemia. CD19 negative, 33 positive, 64 positive, a fraction 14 positive, and 13 positive, and a myeloid phenotype. CGAT essentially showed that the ALL prior to CAR T cells and the AML after CAR T cells were very similar. So this sort of group of patients with an MLL rearrangement may be predisposed to actually undergoing lineage switch under the influence of CAR T cells. And we think that potentially the cytokine storm may be something that drives that in these susceptible patients. So if we're able to get all these patients into CR, some of them can relapse, some of them don't relapse and have long-term remissions. The question is, what's the role of allotransplant for these patients who achieve CR? The short answer is we don't know yet. And we can skip to the end of the slide. But there are really sort of two polar groups. If you look at the first group, a young patient who has no comorbidities, they can tolerate transplant. Perhaps they've got an MLL rearranged leukemia, so they're at risk of CD19 negative relapse. Maybe they've got a CD19 negative population in their blasts. Let's say they had poor CAR T cell expansion, first CR, never been transplanted before, and their B cells have recovered, so their CAR T cells are no longer working. This sort of patient, we'd get pretty nervous about just watching them, even if they had a very clean, very good CR after CAR T cells, and we'd recommend they go for a transplant. Conversely, essentially everything that's the opposite, an older patient, they've had a previous transplant, failed after that transplant, they had very high, very uniform CD19 expression, they had great CAR T cell expansion, they had a beautiful CR, ongoing B cell depletion that it was lasting for many, many months. This sort of patient, you know, we'd probably favour no. But again, the take-home message here is that more data is needed, but that's the way that we're looking at things at the moment. So I'm going to leave ALL and move on to CLL now. Patients, as expected, had a median age of about 60 years old. They were high-risk patients, many with deletion 17p or complex karyotypes. These are all heavily pre-treated with multiple lines of therapy. All of these patients had seen prior ibrutinib. Around about two-thirds, three-quarters of them were either refractory to ibrutinib or they were intolerant. Heavy infiltration of the marrow. Majority of them, 92%, had extramedullary disease, with obviously nodal disease being the most common. Some actually had CNS disease as well. When we look at the response rates, most of the patients were treated with Cy/Flu, and this is really the group that does the best. The overall response rate was 91%, 10 of the 11 patients. And interestingly, when you think about the comparison with the ALL patients, clearance of the bone marrow was extremely effective after CAR T cells. So 91% of the patients were able to completely eliminate disease from the marrow by high-resolution flow. Elimination of nodal disease was a little more tough. The CR rate was 45% in these individuals, but even patients with very bulky disease were able to actually clear that disease and get into a CR. One of the things that is encouraging at the moment is that when we looked at IGH deep sequencing of marrow of the patients who achieved CR, all of those patients didn't have any of the index clone detected, and all of those patients have remained in CR. We haven't had anyone relapse from a CR. So, as usual, longer follow-up is needed, but it's encouraging at this stage when we look at the fact that most of those patients had failed ibrutinib, and I think 4 of them had also failed venetoclax. Moving on to non-Hodgkin's, median age of 56, again, a range of different histologies, but about 3/4 of them were aggressive histologies, heavily pre-treated, many of them having failed prior auto and or allo transplant. We were able to make a product for pretty much all of the patients and in the defined composition in the vast majority. Once again, around about 80% of the patients at the maximum tolerated dose after Cy/Flu, we were able to treat, give the chemo and the CAR T cells as an outpatient. As far as the response rates in the trial so far, we saw the same thing when we compared cyclophosphamide alone or with etoposide. Perhaps I've just killed the slide. We're back again. It would appear somehow I've given this the kiss of death. All right, so I didn't press anything there before or afterward, but I'll claim I fixed it. So similarly to the ALL patients, the addition of fludarabine it made a big difference. The overall response rate went from 50 to 74%, and the CR rate went from 8 up to 44% out of all the patients. I'm not going to talk about it in detail, but dose level 3, which was the highest dose that we studied, was too toxic in these individuals. So if you look at the maximum tolerated dose, which was dose level 2, after Cy/Flu, we had 20 patients. What we found was the overall response rate was 81%, with 50% achieving CR. So we were very encouraged with sort of our optimal regimen. The other thing that we were happy about was that we were able to show a correlation between the peak CD4 and CD8 CAR-T. I didn't do it. The peak CD4 and CD8 CAR. I'm going to step back. CD4 and CD8 CAR-T cell counts in blood with the likelihood of response. So those curves that you can see here and here, oh, there we go, are probability curves. On the x-axis, we're looking at the log 10 CD4 and CD8 CAR-T cell counts. On the y-axis, the probability of achieving a response. Each dot is a patient. These guys responded, these guys did not respond, and this is a mathematically derived curve that shows the likelihood of response. So you can see if you get above about 10 CD4 and CD8 CAR-T cells per microliter, you have quite a high likelihood of response. The other factor that was associated with the likelihood of CR, not just of response, was the addition of Cy/Flu lymphodepletion. So this was one of the first times that people were able to show that the actual dose level and the number of CAR-T cells in blood actually correlated with response. The extent of CAR-T cell expansion at the peak of response is important, but how those CAR-T cells hang around is also very important, and that's why fludarabine or at least some form of appropriate lymphodepletion is so important. And this patient really illustrates that point. The patient had a primary mediastinal B-cell lymphoma with a large renal mass. They had dose level 2, Cy/Flu, CAR-T cells, and then 28 days afterwards, the radiology report was that this mass was bigger, it was still highly FDG avid, and obviously we're pretty disappointed. We reported this as a failure. But we were a little bit surprised because the CAR-T cell numbers in blood were actually still very high at the time of restaging. This is the time of restaging. And so one of the things we were considering was a second dose of CAR-T cells at a higher dose to see if we could make some impact. So we actually biopsied the patient, and the intent of the biopsy was to see if the patient still had CD19 expression on their tumour. And the problem was that we couldn't tell if they had CD19 expression because there was no tumour. Couldn't detect any tumour by flow, but what we did detect was that essentially all of the cellular components in the tumour were actually CAR-T cells. So we're a bit nervous about this, but we decided just to watch and wait, which we're doing now, it appears. And we just rescanned the patient a month later without any further therapy, and he got into CR, and he's still in CR around about a year down the track. So this just sort of highlights how important it is to really rethink actually how we're restaging patients in this sort of immunotherapy era, not just with CAR-T cells, but some of the checkpoint blockade. And this has been demonstrated recently, particularly with checkpoint blockade in solid tumours, that you have to be a little cautious about restaging too early and calling failures. It's very tough sometimes when these patients, we have actually seen that nodal masses can actually grow during that acute CAR-T cell expansion phase. And patients are in hospital, they have pneumonia or something goes on, they get scanned, the radiologist reports there's tumour progression, and everyone panics. All of us, we all panic. And if you just sit and watch and wait, a lot of the time these tumours will come down. Not always, sometimes it is progression. So we're still really defining how we restage these patients. We embarrassingly in the early part of the trial sent someone home about 3 weeks after their CAR-T cells with a big expanding softball-sized mass on their back, and said, sorry, there's nothing we can do for you. And he called us back a month later and said it's now a baseball. Called us back 2 months later and said it's now a tennis, sort of a ping pong ball. Called us back another couple of months later and said it's down to a marble. Like, what should I do? We said, keep calling us. I don't know. But anyway, so the point is that I think we have to be very, very careful about how we reassess patients in this sort of immunotherapy era. So this slide shows the PFS and the overall survival of these patients. Again, they're a very bad group. We haven't reached a plateau yet, but I think our sort of more recent data that I can't sort of share at the moment suggests that there is a fraction of patients that's doing very well. Okay, so we talked about the idea that CAR T cells are a living drug, and what about toxicity? I'm getting very, very nervous here, so I'll speed up. So this slide just shows the two major toxicities, cytokine release syndrome and neurologic toxicity that we see after CAR T cells. And you can see that CRS is essentially a result of T cell activation, commonly manifest as high fevers, hypotension. Patients can develop capillary leak, coagulopathy when it's severe. In the early part of the study, when we really weren't sure how to manage this, around about 20% of patients would end up in the ICU. Now we've only had, in the last 9 months, only 2 patients have ended up in the ICU. So experience has sort of made a world of difference with how we deal with these patients. The neurotoxicity is very interesting. In the vast majority of cases, it's completely reversible, and it can be very, very dramatic. Patients can end up intubated due to neurotoxicity and essentially be in terrible shape, and then a month later they're out riding their bikes. The manifestations are very different. Word-finding difficulties are really common. We've had patients who flipped single words repeatedly for a day, so temperature and privacy were repeatedly flipped by one patient. A couple of other patients have had different combinations. So very unique, very bizarre neurotoxicities that we really don't understand at the moment. But the critical thing is that they're usually, in almost everybody, are reversible, with the exception of some patients, and there appears to be there may be a patient-specific factor that can actually lead to very severe neurotoxicity and even grade 5 toxicities, so deaths basically. The average time in hospital is around about a week. I'm going to speed up here, but the patients that get the sickest are those with the highest tumour burden, particularly in ALL. So you can see up on the y-axis, these guys in black here are the ones who ended up in ICU. Black and blue who ended up, maybe that's appropriate, but ended up getting bad neurotoxicity. So if you can actually take the CAR T cell dose down in these high-risk patients, you can greatly reduce the risk of toxicity. So it's sort of a mitigation strategy of risk-adapted CAR T cell dosing. So I'm going to wind up here, basically saying that in these very sort of poor prognosis patients who are really at the end of their line with what's really a first generation of effective CAR T cell therapies, we get great CR rates in ALL. So absolutely refractory ALL, anyone who can tolerate the therapy you should send for CAR T cells if you can find a trial. Lymphoma, around about a 50% CR rate. CLL, fantastic at clearing marrow, and around about half of them get a CR. And we're still working on trying to improve the therapy, make it less toxic. I won't go into details about combination therapies and things. Lots and lots of people involved with this, but just want to point out Dave Maloney and Stan Riddell, with whom I work really closely on this work. I have questions for the next 4 slides, but I think in the interests of everybody, we'll just leave those out. Thank you.